peds lectures. We're going to hopefully cover most of the rest of peds and a bit more slowly this time as well. So here's the rest of the things we're going to go through, this couple of slides of content. So again, I've tried to sort and kind of categorize any of the curriculum map core conditions, just kind of so it makes more sense and it's a bit less intimidating. And I have added a couple of topics as well I think are useful. A couple of core conditions from PEDS we do cover in other lectures as well. And this is primarily SBA lectures, basically. And I'll address the OSCE topics in like a OSCE document that I'll put out kind of maybe towards the end of next week when I'm a bit less busy with all the fifth year lectures. And so that's just the last few topics we'll be going through today. I think we'll start with an SBA. Right, lovely. So we're thinking about a congenital issue here since we have symptoms pretty soon in life, and we've got bowel obstruction. We've got the green coloured vomit, which is pretty much kind of red marker for this is bowel obstruction. So from the age of the child and the Down syndrome in the history as well, then there's kind of two things we're looking at. It's either duodenal atresia or Hirschsprung's. These both have increased prevalence in Down syndrome and can present in the first few days of life. So what clinches it is this X-ray appearance, which is the characteristic, what's called double bubble. It's where you've kind of almost got a section of the duodenum that's missing. So you've got air in the stomach and then a disconnect and then air in the bowel as well, which leads to this kind of nice characteristic appearance. So we'll briefly touch on congenital diaphragmatic hernia. So this is where you get herniation of abdominal organs into the chest. So the hole that it goes through is usually on the posterior lateral aspect of the left-hand side. And if you don't diagnose this prenatally, like ideally it would all be diagnosed prenatally, but if it isn't, it's an ABCD emergency. You want to immediately be trying to manage their airway, ventilate them, and surgery as soon as they're stabilized. And it is very poor outcomes if it isn't diagnosed beforehand, but fairly decent ones if it is, and can be operated on sometimes in the womb as well. So if you do get a presentation of this in the first few days of life, you have some very characteristic signs, like the bowel wall, bowel signs heard over the chest wall, which is a sign you don't really get in anything else. So on to the second SBA. Okay, lovely. So now we have Hirschsprung's. So again, we've got a presentation the first few days of life, or the first 24 hours here. So you're thinking of a congenital issue, and you've got Down syndrome again. And what you have is a very typical sign for Hirschsprung's, which is this meconium being forcefully expelled on removal of the digit in a DRE. That's a real kind of giveaway that you're talking about Hirschsprung's. And we'll move on to talk about it a bit now. So it's a bit tricky because it can present at various points of life, but most people would present in the newborn period. And it's one of these conditions where there's a bit of a progression investigations. We've got investigations of increasing severity, not severity, invasiveness. So your abdominal X-ray can basically just shows a generic bowel obstruction picture. It might be the first thing you're doing if you wanted to confirm there was bowel obstruction and kind of see if there's any perforation or anything like that. Then the next best one is your contrast enema. So this can show you the characteristic appearance where you get dilated descending colon, but with a normal kind of rectosigmoid part. So you can see where the pointer is, that the rectosigmoid part looks like fairly standard, and then all the way beyond it you've got this very dilated chunky bowel basically. And you get this because the rectosigmoid part of the colon is most commonly affected by Hirschsprung's. And when it is affected, this bit is tonically contracted. So it's basically because of a problem of the nervous innervation of it, it's just squeezing tight and you can't get anything going past it. So that bit would look normal, but then everything else past it will be distended and backed up basically. So I think most people recognize pyloric stenosis due to kind of its fairly characteristic signs. So your projectile vomiting, the projectile part is a real key. Also got the olive-shaped mass that you can feel, which is also fairly distinctive. The age of the infant's important, so be looking at this for a slightly older child than the other conditions we're talking about. Kind of takes a while for it to develop and kind of really cause any symptoms. And you get a hypokalemic alkalosis. This is basically because you've got HCl in the stomach and you're just consistently vomiting that up. But you're not really vomiting much of the alkaline stomach juices from further down in the kind of the bowel and everything. So you get this kind of quite characteristic metabolic abnormality. On to the next SBA. So here we have someone presenting with intussusception. So it's a very typical age for this. The kind of 9-month is the peak age for it. And with this basically colicky abdo pain and the drawing up of the knees in a question is very, very indicative that we're talking about intussusception. So don't rely on the kind of classic red currant jelly stool. Actually, in reality, this is a pretty late and it's not that common a sign. And it's one that kind of clinicians will warn you that it's kind of a bit textbooky. But the right side of the abdominal mass you will see. And so it does have a special treatment. Obviously, it is bowel obstruction, and I can see why a lot of people would go for the tube and the fluids. But intussusception isn't going to resolve itself unless you kind of do something physically to get the telescope bit of bowel out, really. So we'll just go on to talk about that for a bit. So as kind of alluded to, interoception is where one part of the intestine basically slides into the adjoining part. This is also called telescoping. If you think of those kind of old-fashioned telescopes, where you kind of slide one section of a tube into the next. So it usually requires a lead point, and that's kind of a mass in the part that does the telescoping. Usually this is what's called an enlarged Peyer's patch. It's kind of from pre-clin, you might remember these are abdominal lymphoid tissue, but it can also be kind of a more pathological course, like kind of a an abdominal mass or a lymphoma. But if you're seeing this in older children, so kind of we're talking about like 8-9 years old, then it's much more likely to be a pathological lead point rather than this kind of benign Peyer's patch. So it's a classic case of kind of initial versus best investigation, with the ultrasound being what you'd first do, but if it says the best investigation, the contrast enema. And what they'll do is they'll try this air insufflation, so basically putting a tube up and trying to blow air to kind of untelescope the bowel, basically. But you usually need to do this almost in theatre, in a tertiary paediatric centre, because they will need open surgery if that doesn't work. So if an abdominal x-ray is done, what it'll show is dilated bowel loops with no air below the point of interoception. So that point is shown by the pointer, and then above that you can see really dilated bowel loops, and then just nothing, no gas, anything below it. So children often what's called posit their milk, and that's kind of like a way of saying they kind of slightly bring it up. It'll kind of dribble down them, they'll slightly gag a bit. And so kind of reflux kind of almost overlaps a bit of normal physiology. But you might call it GORD in children if you kind of have persistent vomiting, it's kind of troublesome. Then that's when you start to think, oh, this isn't what you call normal positing, we're going to diagnose it as GORD. And it's a pretty regimented stepwise progression from NICE. It's probably a good one to learn, just in a very regimented way. And this is a fairly good thing to do an explanation OSCE on as well. So being able to kind of talk through the conservative measures and stuff like the cornstarch might be more important. And then you can go on to stuff like alginate, which is Gaviscon basically, and you're only looking to get into kind of your PPIs, your real medications in inverted commas, if there's some fairly more severe symptoms going on. You wouldn't rush to give medication to young children. So many kids get constipation. It's one of the most common things that present to GP, and there's two main things you need to know with it. So number one is red flag features for more serious underlying cause. So this is true for any incredibly common pediatric complaints. You need to be able to get past the vast majority of idiopathic presentations to be able to check and look at what you think is more serious. So I'll just kind of go through some of these red flags, try to make them make sense. So if it's occurring from birth or the first few weeks of life, then you're thinking it's more of a congenital issue with the bowel. So you're kind of having alarm bells for Hirschsprungs. Neurosymptoms, as well as constipation, just thinking is more of a neurological cause, and you want to further investigate that. So failure to thrive could be either from hypothyroid. So hypothyroid can occur in kids. It's very important to pick up early due to the developmental concerns, and can also cause constipation if you know from adults. And also celiac is another thing you want to pick up as well, because it can get this failure to thrive, you can stunt their growth, malnutrition, everything like that. And finally, they have constipation with abdo-distension and vomiting. You're thinking of bowel obstruction. So the other thing you want to know, as I said, since it's very common, you want to know the things that are red flags for more serious stuff. but you also want to know how to treat normal constipation, which is going to be coming through GP stores a lot. So how you do this is what's called a increasing regime. So what you'll do is you'll get your Movicol and you'll keep on increasing the dose until they hit, I think they usually say about 2 loose stools a day. You then maintain that level for a week or two, and then slowly start to wean them down off the laxatives. So celiac, as you know and love it, really. The main notes I have and stuff that's different from what you've learned in 4th year is beware of the kind of non-specific presentation in particularly young kids. So your kind of failure to thrive, your tiredness, and particularly a faltering growth presentation. It's one of the first things you want to kind of test and look for. The other thing is in the very young, so below 18 months, sometimes your anti-TTG isn't that reliable. And there's this other antibody sometimes used called AGA. But everything else, you know, is pretty much the same from 4th year, and you can apply it in children. On to the next SPA. So gastroenteritis in children is pretty much usually viral. So therefore, giving antibiotics is pretty rare. And the most important thing with gastroenteritis in children is kind of categorizing them into one of 3 states, which is either clinically shocked, clinically dehydrated, or normal. And that will give you one of 3 managements that we'll go through now. So dehydration and its consequences are by far the most important thing that you need to consider when you're talking about gastroenteritis in children. So shock is mainly if you basically have any deranged vital signs. If you start to see the heart rate or the breathe or the capillary refill time go up, then you're thinking this is shock. As kids are usually pretty good at compensating in general. And remember that hypotension is a very late and bad sign. So pretty much any other clinical signs you can think of will put you in the clinically dehydrated. So with our SBA, the kid was irritable, a bit lethargic, and had decreased urine output. So any other like thing they can mention, but their vital signs are normal, then you're probably looking at clinical dehydration. And if they don't mention any of those other things, then you can probably just put them in a normal category and give them some advice on fluids and everything like that. So once you categorize them, you've got one of 3 managements. So again, just if they're not dehydrated, you should give them advice on fluids. If they are clinically dehydrated, like the person on SBA, so you monitor their weight to make sure that they weren't getting even more dehydrated, and you give them oral rehydration therapy or solution, stuff like dialrolite. And if they're shocked or unable to keep down the dialrolate or any fluids you're giving them, then you want to get them into hospital. So we'll move on to the rest conditions, and we will start with an SBA. So objective testing for asthma is not really used in children under 5. In fact, you rarely diagnose children of this age with asthma actually, and you're looking more at terms like preschool wheeze and stuff like that. And your main goal of any of this is symptom relief. So you just kind of code as maybe suspected asthma, preschool wheeze, and you try to treat any of their symptoms by giving them inhalers. So you'd start with your SABA, and you can move on to inhaled corticosteroid, but we'll go through that in a second. So a lot of the acute asthma management is the same as stuff you've learned. The things to pick out, I think, things to be aware of the differences are the severity scoring is the same, except for you wouldn't use expiratory flow if you're looking at kids under 5, and just beware that the heart rate and rest rate are slightly different depending on the age of the child. But the doses of the medication, the NEBs are a bit maybe just smaller dose, so 2.5 mg of salbutamol, 250 mg of ipratropium, and also you can consider nebulized magnesium sulfate fairly early on if you've got acute severe asthma that you're worried about. And those are pretty much the only differences, I think, in terms of treating acute asthma in children. The other stuff you know and love from what you've learned about adults in 4th year. Oh, I've skipped one. So then if we're talking about chronic asthma, so in the SBA we had a child under 5, where you just usually treat empirically without doing any tests or giving out diagnosis really. Ria was telling me that the only time you really diagnose asthma in a child that young is if they have a strong family history and had repeated A&E presentations with symptoms. Basically, most of the other time, just call it viral induced or preschool wheeze, giving them a SABA if they need it. And the second line step up is this trial of a moderate dose corticosteroid. So what you do is you give them 8 weeks of it. If you stop it and their symptoms come back straight away, you're like, right, that was obviously helping. Let's start them on a low dose inhaled corticosteroid. If their inhaled corticosteroid didn't even clear up their symptoms, I think you're probably barking up the wrong tree and should reconsider. And then there's this kind of weird like mixed response where you have the end of the 8-week trial of the inhaled corticosteroid, and they get symptoms coming back, but it's like more than 4 weeks later. They don't immediately come back. With these, you just redo the trial and see what happens, really. So on to the next SBA. Right, lovely. So first off, you've got a child with a respiratory condition. They're under 1, and they're in the 3 to 6 month range. So your alarm bell should already ring for bronchiolitis. Second off, why have I mentioned the month? Again, UCL things, they don't mention much stuff that isn't relevant. So me putting in that it was in January when I haven't mentioned the month and anything else, probably important. And bronchiolitis is seen massively more in winter. It's croup that's seen more in autumn. And then you've got this 3-day kind of coryzal prodrome, which is again very typical in bronchiolitis. It's a mild fever. If it was a really high fever, they're running like 39 degrees Celsius, probably more considering pneumonia. And then also you've got bilateral chest signs, and that's if you had a pneumonia with bilateral chest signs in a child, you'd be really worried. So onto bronchiolitis, incredibly common, and there's this kind of classic 3 stages of the illness. So you need to warn the parents about this. So they might bring the child in when they're in the 3 days of the kind of coryza, got a bit of a runny nose and stuff like that. You might need to say they might get a bit worse, but we're expecting that. So then they will have this kind of 3 days where they do get worse. They get the chest signs, might get the fever, cough, wheeze, everything like that, and then they'll start to get better. Pretty much the only thing you can do with them is to support their breathing and oxygenate them. So give them oxygen, the SATs are low. If you think they're about to be in respiratory failure, you go for NIV, you go for CPAP, but you basically just manage them on how they're breathing and their measurables are. On to the next one. So I meant this to be a fairly difficult question, but the point is that croup is very common, and the vast majority of cases can be managed at home. Even if the child is getting stridor on agitation, that still would only kind of score a 1 on this Wesley Croup score. I think I wanted to put this in because I was on GP doing the phone consultations. Sound like the child had croup. I was like, oh my god, and the GP was like, my child had croup last week. It's fine. Just move them on. So we'll move on to talk about croup, and it's important because there's a wide range of how sick the child can get. As I said, most of them are just managed at home. It's, oh, they've got a bit of croup, but that can go all the way up to kind of airway obstruction, respiratory failure, everything like that. I wouldn't necessarily learn the Wesley Croup score by heart, but I would have a good idea of what's kind of a reassuring and non-reassuring signs on it, so that your like stridor and agitation, there's only 1 point, but if you're getting any cyanosis, then that's suddenly a lot worse and you're a lot more worried. So dexamethasone is given regardless of severity. If they do present to like a GP or anything like that. And then you've got these increasing escalating measures, including stuff like nebulized adrenaline if they do start getting into airway trouble. And this is what would happen if you x-ray them. This is the steeple sign, where you can see the narrowing of the airway to like a little point, especially like the church steeple. So with a lot of pediatric illnesses, and particularly respiratory ones, I think it's really useful to have a timeline in your head of how old children are when they get them. UCL SPAs, they will be the typical ages. You will have a 6-month-old with bronchiolitis, stuff like that. You won't. So I think it is really good to have crystal clear in your head what age children get certain things, and particularly for respiratory conditions. So they're only over 1, it's not going to be bronchiolitis probably. Another one to talk about is cystic fibrosis. So I think the best way to think about the majority of the cystic fibrosis symptoms is just to think of the thick secretions, and whatever any organ or anything that's got secretions is going to be thick, and think about what that's going to do. So you've got thick secretions in your lungs. That means you're going to get reduced mucus clearance, and this is what leads to the recurrent infections they get. The pancreas secretes things, so you're getting thick secretions of the pancreatic ducts. That's going to lead to your kind of your malabsorption, your deficiency of your vitamins, and your diabetes. And these all twin together to cause the short stature when they do get later in life. Thick secretions in the intestines are what make the bulky stools, And these bulky stools are what leads to the rectal prolapse they get. And I don't know how true this is, but I just thought thick secretions in the nose is what leads to the polyps. Probably isn't, but I think it's just a useful way to think about it. And then finally, your reproductive organs. So this will cause subfertility in females and infertility in males. It's more of an issue in males, and they usually won't be able to conceive, whereas in females, it might be difficult, but sometimes they can. So it should be picked up in newborn screening, but if not, and you'll test them later in life, the initial thing you can do is a sweat test, where you basically test the, I think it's the chlorine in their sweat. And there are a few conditions that can cause false positives. I'll put these in the notes of the slide. And the false negatives is mainly if you get edema of the skin, so it kind of makes the sweat look less concentrated than it actually is. And it's your gene testing for the gene involved, which is CTFR, is your definitive test, and it's a bit of a kind of managing the complications sort of deal with its treatment. So go on to your genetic syndromes. Oh, I've accidentally double-clicked that. Oh well. So yeah, this is a pretty kind of quick one-step SBA that I just wanted to point out anyway. So what you should be able to recognize is from the characteristic features. So this is describing a Down syndrome baby. It's the slanting palpable fissures at the corner of the eyes. The single palmar crease again is alarm bells for Down syndrome, and a large gap between the first and second toe is just describing a sandal gap. And the important thing you need to know is that the most common congenital heart defect they get is this AVSD, where you've got a atrial septal defect, you've got a ventricular septal defect, and you've also got some regurg and kind of insufficiency of the valves, the tricuspid and mitral as well. Down syndrome does predispose you to a lot of congenital heart defects, but this is the one they most commonly get. So Down syndrome is a very important topic, and you should be able to recognize plus describe its characteristic features, the ones from the face, which are on the right, and then the ones on the body are put in the key features. Again, this is very osseable, either in terms of discussing Down syndrome kind of antenatal testing, or even counseling someone who is found out there or given results about a child having Downs. The key thing with any OSCE stuff is you're not supposed to kind of take an apologetic tone. It's supposed to be matter of fact. Apparently, it shouldn't be, I'm so sorry, but it should be just said in a very matter of fact way that it's like a normal thing. So it predisposes you to a multitude of conditions that I'll cover in the next kind of couple of slides. I've got some infographics with all the things they possibly get. But I think the key complications to know for SBAs are mentioned there. So I've already mentioned some, but you've got your the key gene in Alzheimer's disease, or one of them, is located on chromosome 21. So therefore having 3 copies of it means that they very, very often get early onset, kind of quite aggressive Alzheimer's disease. You also get this thing called atlantoaxial instability. I think I mentioned this last year in an anesthetics talk, but Down syndrome and also rheumatoid arthritis can predispose you to it. And this can be dangerous for a few things. If they want to do, say, kind of contact sports, they can cause real damage in their neck. It can also provide difficulties in intubation and ventilation. So you would want to do an X-ray of their cervical spine before any procedure is done. So here in the next couple of slides, I've got all the different possible features you can have, which you can kind of go through in your own time. Would I learn everything? No, but I think it's a good idea to have the key features that I put in the first slide in your mind. And then we're on to the other genetic syndrome that I'd have a really good understanding of. So I think the important things in Turner's are the normal IQ, and due to the exokaryotype, it's just a single copy of the X chromosome, you're always going to have short stature, the delayed puberty, and the reproductive features, because it just inherently comes with only having the exokaryotype. So the other features you can get, they vary in prevalence, but I think that the coarctation of the aorta, the bicuspid aortic valve, and the horseshoe kidney are very important in SBA land, particularly in UCL. They love to mention this horseshoe kidney, which I think is fairly rare, fairly uncommon in Turners, but yeah, horseshoe kidney. And on to our next SBA, which I haven't ruined this time. So what I'm kind of describing here in the I didn't give you the typical L-fine description, but I'm describing L-fine features there. We've got some learning difficulties, but very friendly, happy demeanor, and then an injection systolic murmur. So this is from Williams syndrome. So the L-fine, the feature is called L-fine. I'm not sure how politically correct or not that is. And they have a very friendly disposition as well. I think it was also called happy flapper syndrome at one point. Again, not used for obvious reasons now. And you get this ejection systolic murmur from a very critical thing called supravalvular aortic stenosis. This just means that it's a bit of a narrowing of the aorta just above the valve that causes the turbulent flow murmur. So if we have a bit of a other genetic conditions spot diagnoses, so there's a few kind of features that I've included. So I'll give you just a second to have a look at all of these different things and see if just from a single image you kind of think what's going on, and we'll go through them in a second. So we'll go on to the different ones. So there's hundreds of syndromes. You can get really overboard with it. These are the only ones I think you should know, like be aware of basically. And the kind of pink feature I've put in is the way to pick it out in an SBA. So you've got your other trisomies. So Patau syndrome was what I was trying to show with the picture of the baby's hands was post-axial polydactyly. So that's a key sign in Patau's, because in Edwards you'd have overlapping fingers, but the actual extra digits, and particularly on coming off the end as well, the pinky side, is the way to kind of pick Patau's from Edwards. So Fragile X was the bottom right, and has quite a characteristic look. So the kind of the large ears, everyone remembers the macroorchidism, and they'll also have learning difficulties, and they can get seizures as well. So with Noonan's, I think male Turners, is that accurate? No, but the webbed neck, and you get it 75% in males, kind of is what gives it away from me. But the pulmonary stenosis kind of murmur is also a very key way to pick it out. So we've just gone through Williams syndrome, and Prader-Willi and Angelman, they really like to ask about as a way to prove that pre-clin was worth it. And because they're an example of what's called uriparental disomy. So this is where you get two copies of the chromosome or a part of the chromosome from one parent and none from the other. So it's you get your paternal chromosome deleted in Prader-Willi, and the maternal one in Angelman. And Prader-Willi is really picked out by this insatiable appetite. They'll apparently eat anything that looks edible. You leave it out. You need to lock up soap in some extreme circumstances. So this is about halfway through the lecture. So if people want a 2-3 minute break just to nip the loo, go to the toilet, anything like that, take it here. Right, so I hope everyone's had a little break and we'll continue on from there. So eczema, I think will be fully kind of covered in dermatology, which should be tomorrow. I've got just a brief overview here. The thing about the management is you want the emollient on practically every day applied. So you can do it up to 8 times a day. Want to drench it in emollient, want to keep it nice and hydrated, and you want to spare the steroids as much as you possibly can. And food allergy, I think it was one of the conditions. I think the only thing you really know about it is about this ABC acronym to its management. Just kind of remember the sort of things you need to discuss with them and warn them about. And we'll go on to the first SBA. So we've got a bit of a back-to-back SBA here. So it can be very difficult to pick out measles and rubella apart. I think rubella is actually used to be called German measles, to be fair. So I think the first thing you've got to look at is the prodrome. So they're pretty similar between them, but arthralgia, so the kind of the aching knees, was more indicative of rubella. But the key thing here is the post-auricular lymphadenopathy. That is a key sign when you're looking for rubella out of any of the kind of rashes and fevers. And I didn't really mention that much about the rash, but in rubella it would start on the face and classically spares the limbs, whereas measles doesn't. In reality, it's a bit of a blurred line with this, but at least for SBA land, it's a useful thing to remember. And on to the second one. So there are two key parts of this. Number one is that Rosella is the most common cause of febrile seizures, which is what's going on here. And there's kind of 3 to 5 days of high fever, which then subsides when the rash appears, is your real kind of presentation of roseola to recognize. So this is my big bad table of a xanthan, I can't even say it, when you get a fever and a rash, xanthoma, or yes. So I'll leave most of this for you to kind of like look through at your own time. I think the key signs is the most important part to distinguish from others. So I've included that as your kind of SBA thing for how you're going to tell them apart. I've kind of gone through rubella and measles, rubella. So measles, it's these Koplik spots and they're kind of pathognomic. So the white spots in the mouth is measles, basically. And with scarlet fever, the real thing to pick it out from the other two is the roughness. It will talk about this rough or sandpaper rash, and that's really indicative of scarlet fever. So both scarlet fever and measles can have quite nasty complications, and I've listed these in the notes in full. So on to febrile convulsions. Again, they're very common and very frightening for parents. This makes it a very easy thing to do an OSCE about. They most likely occur early in viral infections when the temp is rising very quickly. This is why you get Rosella being the most common cause of them, because you get a rapid onset, high fever. And it's important to note the complex signs, where if you think that there's something maybe different going on. So the longer seizures, and if it's focal onset, and if they repeat, and if they have any kind of like Todd's palsy, we get weakness after you have the seizure, anything like that, you're looking at a complex febrile convulsion, and you really kind of want to think about different managements for that. So we'll go on to the management. So your first presentation of a febrile convulsion should probably have immediate specialist assessment. And I've listed the full conditions for specialist assessment in the notes, but pretty much, unless you're entirely sure this is a simple febrile convulsion, a child that's over 18 months, and you're sure it's because of a non-serious pathology, that's the only time you wouldn't send them for immediate specialist assessment. So if they're under 18 months, the signs of infection, sepsis can be hard to pick up, so you want to send them to a specialist. And if there's a complex one, anything else like that, they want to see a specialist. And so benzodiazepine rescue medication can be given. This is given by a specialist for use in certain circumstances, and you probably wouldn't be prescribing that. So I think if it's an SBA where you're usually kind of acting as an F1, I think is an unlikely option. So both of these are listed as core conditions. I can't really see how they write SBA on either of them. They're fairly kind of run-of-the-mill issues. And the key thing I want to highlight is about separation anxiety and separation anxiety disorder. So lots of kids get separation anxiety. They don't want to be away from their mum or dad, and they can get a bit teary if they do leave them at daycare. I know I did, apparently famously. But this becomes disorder if the amount of distress is really high, or if it has an impact on the child that's quite long lasting. So if they stop doing normal activity, they stop playing, they won't sleep, they won't eat, if they're away from their parents, this is when you're thinking about it being disorder rather than part of normal kind of growing up and physiology. And finally, we're on to nocturnal enuresis or bedwetting. So you don't treat if they're under 5. It's normal in this age group. Don't get trapped up by that little thing where you're trying to give an alarm to a 4-year-old. But as I said, the alarm is just standard run-of-the-mill first-line management. But be careful if it says something along the lines of, they're going to a sleepover next week and they are really embarrassed about potentially wetting the bed in front of their friends. So that's kind of a roundabout way of saying they want short-term control, and that's when you might pick desmopressin. And onto our social and the kind of behavioural issues and our next SBA. Yeah, so fairly quick answering, as you've got here symptoms of hyperactivity and you've got symptoms of inattention. And the key thing is that it's occurring in 2 domains, and I'll go on to the significance of that in a second. But so you're talking about here ADHD, and methylphenidate is your banker first line option, again, probably known more commonly as Ritalin by its trade name. So I think it's fairly easy to recognize the symptoms of ADHD in a STEM. I think things to remember for the diagnosis is this 2 domains thing. It's not ADHD if it's only happening at school or only happening at home or anything like that. It has to happen in 2 domains. And note the duration of the symptoms needs to be at least 6 months. And also that it has to have an onset before 12. So again, it's a kind of classic, nice stepwise management. So you'd start usually if you're methylphenidate, and then you maybe go on to something ending in phetamine. And finally, or more likely, if you're not tolerating the side effects of the top 3, which are all stimulant medications, then you go on to your atomoxetine or your guanfacine. And these are non-stimulant medication, which usually, given the side effects of those, are too bad. And I think it's important to mention about growth. So it can stunt their child's growth. You're basically putting them on long-term stimulants, and that just overclocks everything. So what they often do is during school holidays, they maybe give a catch-up growth period where they'd cease the medication for a bit. So I don't think there's really that much kind of SBA-able knowledge about autism. I think the main thing to note is about this kind of the diagnostic criteria, which kind of just shows the 3 domains you get features in. So it's kind of a big global impairment in language. You have impairment of social relationships, and then you get these different kind of very regimented routine or rituals or like obsessions or anything like that you can see. And you want to do an early intervention, making sure they might have special education programs, anything to encourage language development, but it's fairly kind of multidisciplinary approach to it. And here are all the other features you can get in autism or associated with it. I won't go through all of these, just added it for your reference. So child abuse is very heavily focused on in pediatrics and A&E and GP and everything like that. So the kind of most like key SBA-able side of it is physical abuse, as the other aspects are fairly nuanced. I think it'd be tough to ask kind of a fairly binary question about it. Some most telling features that kind of point towards child abuse or non-accidental injury are when you have a pre-mobile child, where it's basically hard to see how they would acquire that injury by accident. The child can only really roll around, isn't even crawling yet, how they're kind of falling off things and kind of breaking arms or legs or anything like that. You would be having alarm bells. And the key kind of thing is this like multiple fractures. If they're at different stages of healing or they're at different ages, that's very, very indicative. Posterior rib fractures is something that's quite hard to do by accident and is particularly in a child, and is again a red alarm bell really. And retinal hemorrhages is a really good one to know for exams. Again, you can get them this shaken baby syndrome, whereas if you get a child under 5 who is kind of forcefully shaken, then it's constellation of symptoms. And again, any mention of retinal hemorrhages is kind of in SBA land is pointing towards child abuse. So neglect can be quite subtle, but I think a kind of a key one for SBAs is not giving a child medication and then them coming to harm. So they don't give them, say, antibiotics for a minor infection, and that infection develops and they get more ill. That's a kind of fairly typical thing. And I think it's important for the management to know that you want to be open with parents and kind of say, we are actually looking into this, and kind of really involve them in the whole process, unless you think that will cause harm to come to the child or rarely you. And if you're really worried about something serious happening to the child, you probably want to admit them and get social services involved there. So on to the next SBA. So milestones is one of my least favorite things to learn for medical school, and everyone always does fairly poorly in it. So we kind of pick this apart. Cruising, kind of walking supported, is what you'd kind of expect for a 10 to 12-month-old. By 15 months, you'd expect them to kind of walk unassisted, with referral by 18 months if they can't. And squatting, which I mentioned, you'd expect kind of 18 months old, and a two-year-old maybe start thinking about jumping as well. So you've kind of got several stages of milestones there missing. But both the social, so being dry by day at 2, and the speech, so the following 2-step commands, putting 2 words together, and you'd expect them to know about 50 words, are typical for a 2-year-old. So you've got isolated motor delay, and the most common sign of it, cause of that, is cerebral palsy. And this final sentence, that hand preference before 12 months is something that you'd be worried about cerebral palsy being. So UCL do love a question, just giving you a load of milestones that this kid can and can't do, and then saying, is this normal development, like, or what delay is it? And milestones will come up. So on to cerebral palsy. So I think there can be a bit of confusion around cerebral palsy, because it's a term that encompasses a really wide range of things. It's basically any insult occurring in the kind of like perinatal, like around birth period. That leads to a pathology, which is usually motor, and this usually causes a spasticity. In a spasticity and a long-term one. And again, it's got to be a long-term pathology, which is then non-progressive as well. So there's quite a wide range of severity these children can have, and functional impairment is key as well. So kind of included everything in there that you can have. So you will see intellectual difficulties and epilepsy in a lot of these children as well. But the key thing is kind of the motor aspects, which you see in practically all of them. On to our next SBA. So I've gone forwards and backwards so many times on these kind of type of questions. So I think the Cocker's criteria is actually quite a useful thing to learn, as there will probably be a question picking between septic arthritis and transient synovitis, and these are really good to help kind of pick between the intricacies. So the key here was the coryzal prodrome. So they've kind of got a bit of like an upper respiratory tract infection, runny nose, the like. You've not got a high fever, so you're not looking at kind of your 39-degree fevers, and the child isn't that unwell. A classic sign they're telling you it's transient synovitis will be they're unwilling to weight bear, but they will if you give them paracetamol. In real life, they probably won't actually, but it's a key kind of SBA land thing. And here you've only got mild tenderness, whereas if it's septic arthritis, it'll be excruciatingly painful. And then you've also got these normal inflammatory markers, which, as you can see from the Cocker's criteria, are really key. On to the next SBA. So in any limp in an obese teenager, you're thinking slipped upper femoral epiphysis. And again, so what is the key kind of findings? I think tested this because it's a good thing if you flip this question round, but it's this loss of internal rotation of the leg in flexion is the kind of key finding or phrase. So including some of the other ones that you'd see in hip pathology. You get loss of external rotation, when more seen in kind of frozen shoulder or something like that. So I find the image on the right slightly more helpful when trying to kind of pick this out radiologically. But I'm not gonna lie, generally I just rely on the kind of the history, not really the X-ray. So either that kind of loss of internal rotation and flexion, or the kind of obese teenager, really. So limping child is a common presentation, and again, like your constipation, anything like that, where there's something very common, you need to know the red flags that something more sinister is going on. So again, we'll go through kind of explaining why they're red flags. So it's uncommon for kind of limps to occur in children under 3, and you're thinking kind of more sinister pathology is more likely at that age. So we've talked about that second one. The third one is about septic arthritis. And again, it's classic in an SBA for transient synovitis. They'll start to weight bear if you give them some kind of paracetamol, some analgesia. But in real life, a kid's not going to want to walk on something that's painful. It kind of has a psychological element. And that final one is kind of worried about primary bone cancers that you can see quite relatively commonly in children. So here is your full list of differentials. So we've talked a bit about the top 2 ones. So juvenile idiopathic arthritis should be what you're thinking if you've got more than one joint involved, or any kind of inflammatory joint picture where it'll stress, like morning aching and stiffness that resolves after 2 to 3 hours. Now this can have a systemic form, which we will get regular intermittent fevers. They'll get very high fevers at like a very certain point of the day, and they'll get this kind of pink salmon rash that's very characteristic. And if you've got a progressive limp and hip pain over kind of a weeks to months course, you should be thinking about Perthes disease, and especially if it has these characteristic X-ray changes where you get a widening of the joint space in early disease, which then will progress to a flattening of the femoral head as the kind of the avascular necrosis progresses. On to our next SBA. So this is kind of one where either you recognize the presentation or you don't. So as a clue, there's only 2 reasons why someone would show you a lens specifically as a picture of the eye, and that's a homocystinuria and also Marfan's. They'll get either a down and in or up and out in Marfan's and homocystinuria respectively. Lens dislocation. But yeah, so you've got the learning difficulties, you've got seizures, you've got this lens abnormality, and then you also have this kind of fairly characteristic appearance with the fine brittle hair. So there's many inborn errors in metabolism out there, and this is the only 2 you need to know anything about. And I think you just need to remember a couple of key facts about either. So we've seen homocystinuria and phenylketonuria. I think the key things to pick out on a stem are the musty odor, the kind of blonde hair, blue eyes, and the infantile spasms, and it presenting a lot earlier, so kind of in the first few months of life. On to our next SBA. So just realised that I forgot to swap around the gender and to match the picture, but oh well. So this is a very real classic SBA with you have a follow-up echo in cases of Kawasaki's disease to screen for coronary artery aneurysms, which is important, fairly uncommon, but very important sequelae of Kawasaki's. So you really need to have alarm bells for Kawasaki's if you've got a fever that is unresponsive to antipyretics and goes on for longer than 5 days. If they've got a longer than 5 days history of fever, it's pretty much like you're thinking Kawasaki's until very strongly proven otherwise. And then for diagnosis, you'd also usually have 4 out of the 5 what's called CREAM features. That's an acronym. This is for conjunctivitis, rash, erythema of the hands and feet, adenopathy, so kind of you get cervical swelling, and mucosal, so that's just strawberry tongue, which is what you see in Kawasaki's and scarlet fever, and you also get oral fissures. So this is one of the only times you give aspirin to children. Usually it's contraindicated in under 16s because of the risk, albeit very rare, the risk of Ray's syndrome, which is just this kind of very horrible liver and brain disease you can get if you give aspirin to children. On to the next SBA. So I very cheekily reused an SPA from my renal lecture last year. I did so because I wanted to labour the point about in HSP, you'd only go for analgesia as your kind of standard management, unless you have a few criteria that I'll show you now. So HSP, you might have seen it a bit last year. So it's an IgA small vessel vasculitis, and you get this classic tetrad of symptoms. So the rash is always present. If there's no rash, it's not HSP, and the others are varying degrees. So most people get abdominal pain. The arthralgia you see in about 40 to 50% of the people, and you get about 40 to 50 get renal involvement. So it's usually a clinical diagnosis based on the rash, but you want to screen for renal involvement, and you might want to do a renal biopsy if you suspect renal involvement, just to look at the severity and stuff like that. And then you usually just go for kind of simple analgesia in a kind of bog standard case, but you'd give them pred if they had very severe symptoms, so severe abdominal pain, or they're losing a lot of protein from the urine, which is leading to bad edema. So if you've got edema up to the scrotum, that's very bad kind of peripheral edema because it's gone all the way up. So on to our next SBA. So a bit of a mean heme style question. So what we have here is hemolytic uremic syndrome. So you've got a child with nausea, They've got these petechiae, so you've got some platelet dysfunction. You've got severe renal dysfunction. They're anuric. And you've had a recent episode of diarrhea and vomiting, which is kind of giving you that E. coli history for your HUS. And in this, you get a few things. So you get renal dysfunction, you get thrombocytopenia, and you get microangiopathic hemolytic anemia. So the most specific of these to hemolytic uremic syndrome is the microangiopathic hemolytic anemia. And any micropathic angiopathic kind of hemolysis will cause schistocytes by mechanical shearing. So the key thing is that thrombocytopenia can be seen in ITP as well, but schistocytes is very specific for microangiopathic hemolysis, which in kids you basically think of hemolytic uremic syndrome. So this is another topic that was probably touched on a little bit last year, maybe in heme. So kind of mentioned the cord triad of it. And I think that's something to note is that the renal involvement is often very severe and kind of 50 to 60% of the time will need dialysis. Then you've got ITP, which commonly you'll see as a differential as well. Again, another topic you've probably done a little bit in heme. So the key is that in every aspect, it's only an isolated thrombocytopenia with nothing else going on. So in terms of symptoms, in terms of the blood film, the blood count, everything just thrombocytopenia. And your treatment is basically based on initial severity. So are they bleeding? Do they have purpura? Stuff like that. And if it kind of keeps on coming back, but your default is probably to not do anything with them. I think this is our final SBA. So this is a red flag. Basically, you're thinking when you have an abdominal mass about either neuroblastoma or Wilms, and you don't want to wait 2 weeks. You want 2 days for any kind of child cancer presentation. So for this abdomen mass, or for your heme cancers, you would look to do a 48-hour FBC. Unless they've got hepatosplenomegaly, then they go straight to a pediatric review. So I'll just kind of go through some of those cancers just quickly now. So your nephro and your neuroblastoma both often present with an abdomass. In your Wilms tumor, it's a primary kidney cancer seen pretty much only in kids, and you can get painless hematuria, enlarged abdomass or enlarged abdominal organ, which would give you straight to 48-hour pediatric review. Neuroblastoma is derived from neural crest tissue, and therefore it can be picked up by these adrenal markers of VMA and HMA. Then retinoblastoma, the main kind of things you need to recognize are you've got a loss of the red reflex of the eye, or if you've got this white reflex, which is also called leukocoria, they need to go straight to opt-out urgently. They should be screened at their newborn assessment at kind of a few days of life and 6 weeks for this. And then you've also got your ALL. So this is a leukemia usually seen in kids and pretty young children at that. And just like AML is diagnosed when you've got 20% blasts, but here it's lymphoblasts in the bone marrow. So thanks very much for sticking with me for 2 lectures of pediatrics. Please do feedback. I do look through it and kind of try to change it. Lectures for anything you guys say, and it's obviously very useful to us. And are there any questions? Isaac, have you posted the feedback form?
Yeah, I'm just doing it right now.
And please, I know you guys had to kind of rush off to go to the MedSoc lecture last time, but if you didn't have time for feedback for the first one, I might see if I can find the link, but I'd appreciate any feedback for that. I think Ed posted it on the event for last time. But please let me know if there's any questions. Otherwise, have a good evening. Lovely. Send them in, please, Shwat. Why not urgent abdo ultrasound? Or does the so you would want to send them straight to pediatrics. Basically, this is a fairly guideline based thing, and you're in a GP, and this is a fairly rare childhood cancer. I think the likelihood that you have a technician, that could do it well enough to pick up a rare childhood cancer in a GP surgery is pretty unlikely. So you'd want to send them straight to a pediatric specialist. Why do you wait 2 weeks for retinoblastoma but 48 hours for other childhood cancers? So again, fairly guideline-based thing. My best guess can be that the loss of red reflex or leukocoria is a sign that's probably more common for cataracts, and there are other benign pathologies that can cause it. Whereas if you're looking at an abdomass or kind of painless hematuria in children, that's something you really are worried about and you want to send straight to a specialist. Remember, with your blood cancers, that you have that division where you've got either kind of petechiae purpura or hepatosplenomegaly, you'd send them straight to hospital. But in other cases, you do a 48-hour FBC, so that you just want to do a full blood count and then see what that said. So I think it's basically on how likely a certain sign is that it's due to a cancer, rather than could be something benign. But it's something I've just taken from guidelines, I'm honest. Anything else? I can't seem to see the conversation really.